This is our second lecture in the series Pharmacology related to the endocrine system. In this unit, we're going to look at the gonadal hormones, oral contraceptives, and erectile dysfunction medications. Your objectives during this session are that you should be able to identify at least 2 clinical indications for the administration of female sex hormones. You should be able to list at least 5 adverse effects of estrogen therapy. Describe how hormonal contraceptives work and describe their adverse effects. And then explain how erectile dysfunction medications work. So we're going to start this section with female sex hormones. So what are they? And there really are 2 primary female sex hormones, estrogen and progesterone. And what do? Basically, they're responsible for stimulating the development of the uterine lining and of the mammary glands. Now, why would we want to use these if we're making them on our own? Well, there's a couple of reasons. Main uses are for hormone replacement therapy. You'll see that abbreviated capital H, capital R, capital T. Oral contraceptives, fertility enhancement, and sometimes we'll use them in the case of certain cancers, such as prostate cancer and a non-estrogen dependent breast cancers. You may see them also used in therapy when treating those cancers. In children who have something called hypogonadism, particularly females who have that, which is they're born with ovarian failure or non-existent ovaries, they will require replacement therapy of the female sex hormones so that they can complete puberty and continue to grow normally. One of the things that's been kind of interesting with this, as they started using more hormonal replacement therapy in adults, they've discovered that women had a lower chance of osteoporosis when they were taking these medications. So kind of as an outgrowth then of hormone replacement therapy, we have seen female sex hormones prescribed in the case of osteoporosis so that we can slow down the development of that disorder. So we've talked a little bit about hormone replacement therapy, but I want to talk a little bit more about it. The most frequent cause of female hormonal deficiency is removal of the ovaries. So most frequently, if someone has had bilateral oophorectomy, their ovaries removed for one reason or another. Other reasons would be menopause and perimenopause. Perimenopause being that time right before, early on before someone is truly going through menopause. It's characterized by a significant decrease in the female sex hormone production, particularly estrogen and the progesterones, decreased frequency of ovulation, and menstruation starts to decrease. Initially, what happens, you get a period of physiological and emotional adjustment, and during this time, some people experience symptoms such as being tired, they get hot flashes, they get nervousness, anxiety, irritability, or even depression in some women. And then you get tissue changes that'll go along with it in the endometrium and in the vagina, such as they atrophy, get irritation, and dryness can also take place in these areas. When someone is truly in menopause, it's defined as the complete cessation of the menstrual period for 12 months. accompanied by a decreased estrogen level of less than 50 picograms per ml and a decreased FSH level. Again, when someone is at this point in their physiological development, we may see depression again, some anxiety, muscle spasms kind of stuff that go on that could also lead to someone being given hormone replacement therapy to alleviate those symptoms. Again, both of these are not abnormal. They're a normal part of the maturation process of a female, but some people have exaggerated symptoms with it that need to have treatment. So options, that can be given to these people would include just giving them estrogen only, or you can give them estrogen and progesterone. So that kind of comes up to the doctors deciding which way is best to go for the person's symptoms. Now, there are some adverse effects related to hormonal replacement therapy, and that would include things like nausea, vomiting, headache, dizziness, increased irritability, which you're probably already trying to get rid of, and depression, fluid retention, breast tenderness, and weight gain all come along with those. So they certainly are not without their side effects. Now I do want to talk a little bit about the Women's Health Initiative. This was a very large clinical study that was done, involved more than 16,000 women over the age of 50. And it provided results that have kind of curbed the enthusiasm for prescribing hormone replacement therapy in postmenopausal and menopausal women. What the study showed is that women who were taking a combination of estrogen and progesterone daily for at least 5 years had an increased risk of heart attacks, thromboembolisms, stroke, breast cancer, and dementia. And that would include things like Alzheimer's disease. This was also people who were just taking estrogen alone without the progesterone component had an increased risk of developing endometrial cancer. And in fact, it was about up to 6 times higher than women who had not taken any endogenous estrogen. So there are some significant risks that women do need to consider from this study before deciding to take hormonal replacement therapy. Are the symptoms that severe that it would require putting you at this risk? Now, there was the good piece of news that did come from this was that it also found that women who were taking on estrogen replacement therapies ended up with a decreased risk of colon cancer and the decrease in bone fractures. And that was alluded to a little bit ago as possibly could be an indication for taking estrogen. Now, we did allude a little bit to the osteoporosis for estrogen. And basically, as estrogen declines in the body, bone reabsorption begins to exceed formation. So you're absorbing more bone than you're forming. That tends to lead to a decrease in bone mass that's called osteoporosis. The incidence of fractures when you have osteoporosis is much greater, and it's particularly greater in postmenopausal women, about 6 to 1 compared to men of the same age. But it does occur in both men and women. So, one of the things is women who have established osteoporosis, they might require a multidisciplinary approach to treating it in order to eliminate some of those fractures. And some of the things that could be eliminated would be cigarette smoking. If they can increase their calcium intake, they can decrease their caffeine intake. If they have a sedentary lifestyle, if they can get up moving around, that may help. And then we may want to take a look at their estrogen levels too. Risk factors that put women at risk for developing osteoporosis would be if they have a family history of osteoporosis. We do see it more in Caucasian or Asian women. Women who have a lean body mass or are short tend to have more cases of osteoporosis. And if they have go through menopause prematurely, that could precipitate osteoporosis. So as we said before, for those particular women, even though we look at a variety of other things and can try changing other lifestyle things, we may not be able to totally control it with just lifestyle changes. So we might need to introduce estrogen, which has been shown to increase the density of the bones. One particular medication, Evista, is a synthetic estrogen, and it particularly targets receptors associated with the bones, but tends to leave other body parts effective. So Evista has been a fairly good solid estrogen component if we need to give it to someone for the case of osteoporosis. Now, estrogens themselves do occur in nature. We have something called phytoestrogens, and phytoestrogens are in plants, and they can be absorbed in the body from plants or from sources of the plants that contain the phytoestrogen. A couple of those would be one is spearmint. Spearmint has phytoestrogen in it, and soy products. Anything made with the soy is a good source of phytoestrogen. It has been shown, some studies have shown that soy added to the diet will decrease total cholesterol and LDL cholesterol too. So that's another alternative source of giving some estrogen without actually putting a chemical into the body. Now, there are some potentially life-threatening adverse effects from the estrogen therapies. For one, increased risk of thromboembolism, which could lead to blood clots, which could lead to stroke and peripheral vascular disease. Breast cancer is another risk for estrogen therapy. So someone who has a history of breast cancer should not be using estrogen therapy. And keep in mind that this also includes women who want to take oral contraceptives, and we'll talk about those in a little bit here. But oral contraceptives have an estrogen component to them, and so that puts them also at risk for these same things. Never should these estrogens or progesterones be used in someone who has a history of thrombophlebitis or a history of stroke or breast cancer or liver disease, breast lumps, or unexplained vaginal bleeding. In those cases, we should avoid estrogens at all. Now, we kind of alluded to oral contraceptives here a little bit. So kind of following on through, we're going to talk more about contraceptives that use these hormones, particularly estrogen and progesterone. So there's a couple different ways in which we get hormonal contraceptives, or we can deliver hormonal contraceptives. One is through injection. You may be familiar with and heard people say Depo or the Depo shot. Depo estradiol is a very common one, and this is a medication that is suspended in oil and administered intramuscularly once a month. And because it's suspended in oil, it has a slow release, and one injection will last an entire month. IUDs are another form, and the IUDs, the implantable uterine device, has embedded within it the hormones that are also slowly released. These are generally replaced every 12 months. NuvaRing, you may have heard of, is a ring that is placed in the vaginal canal and continuously releases the drugs into the surrounding tissues. And then there's birth control pills, which are taken orally, that contain the hormones and will aid in contraception. How they work is that whenever we're giving these levels of estrogen and progesterone, we are keeping them that high that hopefully we are preventing ovulation. And if we're preventing ovulation, then pregnancy cannot occur. They also work secondarily in that by maintaining that high blood level, the body actually kind of tricks the body into thinking it's kind of almost already pregnant. So as a result, it doesn't build up a uterine lining because it doesn't need to. Without that extra uterine lining buildup, if conception does occur, it cannot implant into the uterus, so it prevents pregnancies from implanting in the uterus, and therefore doesn't implant and is expelled, and pregnancy does not occur. Indications and reasons we might want to use oral contraceptives would be in non-menopausal women, menstrual disorders. Sometimes we get women who have amenorrhea, no menstruation, or painful, difficult menstruation known as dysmenorrhea, and it may alleviate some of those symptoms by using estrogen, progesterone, or a combination of those. Certain cancers may indicate the need for, again, the presence of sex hormones. Cancer of the prostate gland is one in which if we give hormonal therapy, it'll help alleviate or decrease the spread of prostate cancer. If oral contraceptives are being used, women should be encouraged that if they are planning on conceiving, want to achieve a pregnancy, they should discontinue that oral contraceptive for at least 3 months prior to conceiving, prior to attempting to conceive, because they want to make sure that all those hormones are out of their body and their body is back to a normal state prior to conceiving. There have been some cases documented of birth defects related to women who have high estrogen levels, particularly because they are taking oral contraceptives when they conceive. Little note that you may hear some things such as monophasic and biphasic and triphasic when you're hearing about oral contraceptives. What that word monophasic means is that there's one fixed release amount of estrogen in each pill. From 0 to 21, they get the exact same amount of estrogen, and then for the next week, there's usually no estrogen. With biphasic and triphasic, what happens is you usually see a variety of pill colors, and in each phase is a different strength of estrogen in relation to progesterone. So they vary it. If there's 2 different colors, there's 2 different amounts of estrogen. If there's 3 triphasic, there's 3 different amounts of estrogen in relation to the progesterone in the pills. And again, that just comes down to what seems to work best with each person, each individual. Some work better for some than others. So, adverse effects, particularly of oral or hormonal contraceptives. Primarily the big things, if you think back to what we said about estrogen, they all contain estrogen. So, or most of them contain estrogen. So, we're looking at thrombophlebitis, pulmonary embolism, stroke, and heart attacks. Anything where clots are formed, they are at risk for. Now, there are things that will make these adverse effects more prevalent. Smoking, hypertension, obesity, and diabetes. So if someone has one or more of those, they are much more at risk of any of those adverse effects from using hormonal contraceptives. And you did have a medication on your drug summary that was in this category, and that one was Yaz, and you've seen that kind of in and out of the news a lot. It kind of gets back and forth and gets a little controversial periodically, so thought that might be a good one for you guys to kind of read up on a little bit. All right, I'm going to switch to the male side of things a little bit here and talk about erectile dysfunction, otherwise known as impotence, or the inability to achieve or maintain an erection. Things that put men at risk for this would include hardening or narrowing of the arteries because of decreased blood flow to the penis, injuries to the spinal cord causing nerve damage, smoking, and diabetes will also contribute to ED. And if we go back to the physiology, if you remember, you have to get increased blood flow to the erectile tissue in the penis in order to achieve and maintain an erection. A normal process, the male brain receives a signal to release nitric oxide, which is an internal vasodilator, similar to nitrous oxide that we talked about a little while ago. And the body releases this to where increased blood flow is needed, particularly in this case the penis. Nitric oxide will then stimulate an enzyme to be released that relaxes arterial smooth muscle. Once the smooth muscle is relaxed, the blood flow can rush into the tissue and the penis erects. So, you need to understand that these drugs do not increase or affect erection in men who are not impotent, and they do not affect an erection that's not the result of sexual stimulation. Erectile dysfunction drugs increase the blood flow to the penis to help produce that erection. They will only increase it as a result of the brain triggering the release of nitric oxide. These medications basically increase the amount of enzyme that's available so that when nitric oxide is released, now there's enough enzyme available to cause the arterial relaxation of smooth muscle and allow blood flow to come into the penis. If there is no sexual stimulation, there is no release of nitric oxide, and there will not be an erection occur. And if someone already has enough of the enzymes in their body to cause this, to have a normal erection, having more in there isn't going to change anything. Adverse effects that we most frequently see from these medications are usually headache, flushed skin, maybe an upset stomach, some, nasal congestion, diarrhea, and possibly a rash. Occasionally we hear people developing priapism, which is a prolonged erection lasting for more than 4 hours. And in that case, we have a serious issue that someone needs to go to the physician, go to the ER, and get treated for. What these medications do, remember, is they're dealing with dilating blood vessels. So if someone's already taking nitrates, and if you remember from way back when we talked about nitrates, they're already taking them, the blood vessels are already dilating to begin with. And then if we add these medications on top of it, we can cause extreme vasodilation, which then causes hypotension, and can cause someone to pass out, and can even cut down blood flow to vital organs. So if someone is taking nitrates, they should not be prescribed these medications. And if someone has a disorder that would put them at risk for priapism, such as sickle cell anemia, they should not take these medications. So when you see the warnings and you see the commercials on TV that say, you need to go and see your family physician first, it is true. They really do. These are not just innocuous medications to just take at whim. And, you hear them being sold, here, there, and everywhere on the street. But they really can put someone at physiological risk if taken without the care of a physician. Again, some of the ones that you may be very common or familiar with from various commercials on TV, Levitra, Cialis, and Viagra. Just a little story to kind of end off this section. How Viagra was actually discovered was interesting in that it was originally being a trial medication to see if it could prevent heart attacks. It was thought that it would dilate the coronary arteries. So they had two groups of men, and they put them each on, one group was on a placebo, and one was on what is now called sildenafil, which we now call Viagra, and gave the medications, and then of course they monitored them for heart attacks, and they really didn't see any significant decrease from the placebo group to the medicated group. So they decided to discontinue the trial. And when they were discontinuing the trial, and they went to take the men off of sildenafil that were on it, they did not want to discontinue it. And they're going, why do you want to keep taking this medication? Well, lo and behold, they find out that, wow, they were having, which they may not have admitted before, they were having issues with erectile dysfunction. And their erectile dysfunction was non-existent while they were on the medications. And so, turn of events, pharmaceutical company goes, I'm going to take advantage of, this. We're going to look at remarketing it instead of as a coronary vasodilator, as an erectile dysfunction medication. So that was sort of how that came about. So that story will end our section on dealing with the female hormones and medications of erectile dysfunction.